I remember the OB without looking at me, just looking at the monitors. And she said, oh, she's actually fine. Same monitor, same readout, interpreted one moment by the nurses as an emergency, and then the next moment as totally normal.
Hello and welcome to the Be Well Baby podcast. I'm your host, Dr. Emily Spaeth.
If you've listened to the first few episodes by now, you know we are all about one thing here, moving you from surviving to thriving. And that starts with informed choices, real, honest information, so you can make decisions that actually align with what you and your baby need, not just what feels safe or what everyone else is doing or what a hospital liability team prefers. Today, we are talking to something that, according to this New York Times article that dropped, happens to nearly every woman who walks into an American hospital to give birth. It's routine. It's presented as protection. And decades of research says it often doesn't help. In fact, it frequently can cause harm. Today, I am talking about continuous fetal heart rate monitoring. I'm going to talk through what this New York Times article talked about and tell you a few of my own personal experiences with this so that we can all move forward knowing the latest evidence. The craziest thing about research is that it takes up to 20 years for the latest evidence to actually come into practice. So what we actually know to be true in evidence may not be what your hospital system is doing. So the first thing I want to talk about is this story about Sanquinese. So this woman named Sanquinese Hankerson Pinky, she's a lawyer in Florida. And in the New York Times article, they went through her story. So in March 2021, she went into labor. Her doctor looked at the fetal heart rate monitor and saw what appeared to be a concerning pattern, the heartbeat dropping. And based on that one readout, the doctor recommended a C-section. Sanquinese agreed. She said, and I quote, "Seeing the heart rate dropping on the monitor, it made me sick to my stomach." Yeah, of course, it would be terrifying not understanding what fetal heart rates are supposed to do and being told your baby's heart rate is dropping and that means we need to have a C-section. Terrifying, right? So she had the surgery. And then a couple of years later, she tried to get pregnant again. And then she tried to get pregnant again. The following year, when she did get pregnant for the second time, something really scary happened. Her placenta ended up growing into the scar tissue left behind from that first cesarean. This is a condition called placenta accreta, where the placenta actually grows into the uterine tissue. It's rare, but it's becoming more common as C-section rates climb. And it's life-threatening because the placenta and uterus are fused together. Natural labor or labor starting on its own could have killed her. That's so scary. So she delivered 5 weeks early. Her newborn needed a ventilator when they were born because they were born early. And when the doctors couldn't safely remove the placenta, they ended up having to remove her entire uterus. I know. So at 37 years old, Sanquinese had no choice but to accept that she would never have another child. And I'm getting tearful just talking about this because this sort of thing happens frequently. And her story is not rare, unfortunately. Here's the thing. She might not ever know if that first cesarean was actually necessary. The hospital that she gave birth at has actually closed since then. But what we do know is that that initial intervention did create a cascade of consequences that fundamentally changed the trajectory of her life. And Sanquinese is not the only person with a story like this. So I had one client, we're going to call her Alice, and here's a brief version of her story. She was pregnant, and at around 36 weeks, her water broke. This is called PROM or PROM, premature rupture of membranes. It actually happened to me as well. It just means that your water is broken before you actually go into labor. And Alice felt that she would easily go into labor when her body was ready. She really felt like she was on the precipice of going into labor, but there was a very specific hospital where she felt safest giving birth. So when she went into labor, she went to that hospital and she was told that that hospital was on divert. That means they were at capacity and she'd need to go somewhere else to have her baby. She did not feel safe with her other options. So she persisted. And the hospital told her if she agreed to be induced right away, she could stay. Now, that is a conversation that we will need to have about medical coercion another time. But here's what happened. She chose to get induced at the hospital where she felt safe, even though that wasn't what she wanted for her birth. She did not want to be induced, and she didn't feel like her body was ready in that moment. And here's the thing about induction. Sometimes babies don't tolerate it well. Pitocin, misoprostol, these are powerful drugs that force contractions. They work well, and we are so glad that we have them when we need them. But they're intense, and her baby did not tolerate the induction well. The monitor showed what the hospital interpreted as fetal distress, and she ended up with an emergency C-section. But here's the question. Was the baby actually in distress? Or was the baby responding normally to an intervention that they didn't really need in the first place? This is a pattern that I see in my practice, and it's exactly why this research matters so much. And honestly, I lived through this myself. During my own first birth, I mentioned earlier that I had PROM. I had premature rupture of membranes. My water broke at 37 weeks and I was not ready to have a baby. I think the first words out of my mouth were, "We're not ready." And at a certain point, an OB came into my room and started talking about a cesarean because of what my baby's heart rate was doing on the monitor. I remember the moment because I was so far gone in my own labor land, but the OB was not looking at me, looking directly at the monitors. And I remember exactly where my husband was, exactly where my sister was, exactly where my midwife was. And because I had had a home birth midwife, we transferred to the hospital. And I remember the shift in the room when the OB walked in and started talking about what it would look like for me to have a cesarean. And then I remember the OB, without looking at me, just looking at the monitors. And she said, "Oh, she's actually fine. Same monitor, same readout, interpreted one moment by the nurses as an emergency, and then the next moment as totally normal." So that's the problem. It's so subjective.
If you are looking for a pacifier that will support your baby's oral motor development, the Nini is my favorite. So it's wide at the base and soft at the base, and it gets firm at the tip, just like a breast and a nipple and an areola. It's not as firm as a traditional pacifier, so it allows your baby to get used to getting organized around a softer surface. Use the code BeWellBaby for 10% off at checkout at ninico.com. Thanks for listening. Let's get back to the episode.
Okay, I want to back up because let's talk about what this technology is and why people actually use it. To quote the New York Times article by Sarah Cliff, nearly every woman who gives birth in an American hospital gets strapped with a belt of sensors to track the baby's heartbeat. Those sensors are meant to keep track of the baby's heart rate all the way throughout labor. The monitor produces a readout that shows how fast or slow the baby's heart rate is beating and how it's responding to contractions. And it's extremely useful for nurses and doctors who know how to read them because it gives them data that they can look back on, and it can be extremely reassuring when everything looks good. The promise of this technology was huge. In the 1950s, a Yale obstetrician named Dr. Edward Hahn was studying fetal heart patterns, looking for signs of oxygen deprivation. When he published his work in the early 1960s, the technology was marketed as revolutionary. Life magazine in 1969 wrote that this new system could save as many as 20,000 babies a year. That is remarkable, right? And device companies sold hospitals really hard on another benefit: efficiency. The New York Times article talked about ads from the 70s and 80s where they marketed that one nurse could monitor 8 patients at once instead of doing periodic stethoscope checks. One ad said the monitor was like keeping a nurse at every bedside, except, cheaper. By the 1970s, continuous monitoring became standard, and it's still standard today. Nearly every person in a hospital experiences that as just how birth works. But now I want to talk about what the research actually shows. In 1976, researchers did a randomized controlled trial. This is a gold standard for a study. It randomly assigned some women to continuous monitoring and others to regular stethoscope checks. The findings: continuous monitoring did not reduce stillbirths. It did not reduce newborn deaths. It did not prevent cerebral palsy. It did not improve outcomes for healthy babies. Bummer. In fact, the only clear finding was this: women who are continuously monitored had significantly more abdominal births, or cesarean sections, however you want to phrase it. That trial was followed by more studies, and in 2017, a rigorous review found the same thing. Compared to periodic stethoscope checks, which is the gold standard for any community midwife, continuous monitoring did not prevent stillbirths or cerebral palsy in healthy pregnancies. And that's really what it was marketed to do. It was going to prevent cerebral palsy in every case. The 2017 study did show a slight decrease in neonatal seizures, but, and this is important, that did not translate into better long-term neurological outcomes for babies. And here's the part that just floored me about this article and the fact that everyone doesn't know this. But the rate for abdominal birth between continuous monitoring versus periodic stethoscope checks went up by 63%. 63%. What? Okay. So here's the brutal truth. Healthy babies have highly variable heart rate patterns. We want variability. A completely healthy baby's heart rate can speed up, slow down, have irregular beats, and that is typical. One of the things, and this is not a scientific anything, this is just my own personal experience, but I feel that it's very relevant here. When I turned to my midwife in the hospital and looked at her and was like, should I be afraid right now? Everyone seems afraid. She looked at me and she said, I think your baby is sleeping. And I looked at her and I said, wow, that makes a lot of sense. I would be sleeping too right now, except that I'm in labor. And she said, yes, it's okay for your baby's heart rate to be lower right now. And as soon as she wakes up, it'll probably speed up. And she also probably was not enjoying the Pitocin that I was on. There's so many reasons, but in any case, when you're staring at a monitor all labor long, you see every single variation. And many doctors interpret ambiguous signals as signs of fetal distress. An obstetrician at the University of Chicago, Dr. Emmett Hirsch, has been really vocal about this. He calls continuous monitoring the worst test in medicine, and that is a quote. And he's not alone. Other experts have called it useless. Yikes. And pathetic. Wow, those are both quotes. One of the most striking quotes I found came from Dr. Stephen L. Clark, an obstetrician at Baylor College of Medicine, who has extensively studied this technology. One of the most striking quotes from the New York Times article came from Dr. Stephen L. Clark. He's an obstetrician at Baylor College of Medicine who has extensively studied this technology. He said, we may be the only specialty that continues to do major abdominal surgery without a shred of evidence of benefit. We just plow blithely on. Think about that. We have decades of research showing this doesn't prevent the outcomes it claims to prevent, and yet we do it to nearly every birthing person in America. So why? This is where it gets just frustrating, because the answer isn't about patient safety. It's about business and legal liability and institutional inertia. Here's one reality. Obstetricians get sued more than doctors in almost any other specialty. When there's an adverse outcome, a baby with cerebral palsy, for example, lawyers pull the monitoring strips as evidence every single time. Expert witnesses on both sides interpret those strips completely differently. One says, look, the baby was in distress here. And another says, no, those patterns are completely normal. It's subjective. It's what one legal expert called very squishy, which is a great term for something that nobody understands. So some doctors have told researchers, Even if I don't think the monitor helps, if I don't use it, a court could find me negligent. So the monitoring becomes legal protection, not medical protection. And then here's the thing that should make you really angry. Recent malpractice cases have set record verdicts: $207 million in Pennsylvania, $950 million in Utah, with these interpretations of monitor strips as the centerpiece. Meanwhile, no studies have shown that performing a C-section based on fetal heart patterns can prevent cerebral palsy. But juries don't know that. So the system incentivizes more monitoring, more abdominal births, and more risk. Now, we all know the system is broken, but sometimes it helps to understand how it's broken, and then maybe we can fix it. So there's also money involved. Big hospitals are opening remote monitoring hubs and if you're interested in this, go read that New York Times article, because there's this big picture of a remote monitoring hub, and it's just sort of flabbergasting to think that there are just people sitting there looking at strips and there are actual humans laboring anyway. But these remote monitoring hubs are where nurses are sitting there watching the screens of heart data from dozens of miles away. And they market this with the language like cutting edge AI technology and the highest benchmarks for safety. One hospital estimated that they saved $13.5 million in malpractice costs in the first 2 years of their remote hub. Another hospital executive said the hub was helpful partly because it just looks good, and that sometimes matters more than about anything in legal disputes. I know. Software companies are selling AI algorithms that claim to decode fetal distress from the monitor data. One company called Perigen claimed on its website that 50 studies backed up their products. But when journalists asked about those studies, not one of them actually showed that the AI improved birth outcomes. One was literally about how to suture a C-section scar. The company removed the list after there were questions about it. But in the age of AI, it's so easy to sort of create things just out of nothing. Even the newly updated guidelines from the American College of Obstetricians and Gynecologists, ACOG, it was released this fall, acknowledge that AI software for fetal monitoring is unproven, yet they still recommend continuous monitoring overall. Meanwhile, other wealthy countries, Canada and Britain, have cautioned against routine use of continuous monitoring in healthy pregnancies because they are saying the evidence doesn't support this. And that's true. But in our country, the legal system almost takes precedence. And then there's one piece of this that I think is even simpler. It's that inertia. So many obstetricians practicing today have never worked without a monitor. It's just how they practice. Same with the nurses. Everyone's used to it. Some people genuinely believe that it's helpful for them, even if studies haven't shown it. And others say, well, it's hospital policy, so it doesn't really matter. And one doctor put it really bluntly: it's just easier to keep patients hooked up continuously. It's an ease of manpower issue over the science. And that's honest, but it's not a good medical reason.
I need to tell you guys about the Cerise Chill because it absolutely changed the way that I feel about pumping. First of all, it's so slick. It's basically a cooler that you pump into. It has all these different parts that fit together to form different cups, and then it all fits back together to keep your milk cold forever. I took 4 of these things with me across the country, and it kept my milk absolutely cold and actually started freezing it. So the Cerise Chill, I'm not even going to say more. You should just go check it out. There's a link in the show notes if you want to learn more.
Okay, now let's get into what fires me up most about this topic, because it's a perfect example of what happens when we accept things as just how it works without asking questions. In the Beyond Birth Blueprint, where we dive into all the birth prep things, we are all about informed consent, informed choice. No judgment. It doesn't matter as long as you have all the information before you make a decision. So when continuous monitoring is presented as standard of care, as protection, as something that really looks out for your baby, but the research shows that it doesn't prevent the outcomes it claims to prevent, and it significantly increases the likelihood of major abdominal surgery that comes with real medical risks, infection, hemorrhage, complications, and future pregnancies. And not to mention all of the baby side things, the feeding difficulty, everything about abdominal births that makes just recovery more complicated. Is it really protection then? And not to mention the fact that when you are hooked up to something, you can't move your body as easily. And one of the huge hallmarks in what I teach is how to allow your body to move in the way that it wants to move. So the bottom line here is that continuous fetal heart rate monitoring for a healthy pregnancy, the research suggests that it is more likely to cause harm than prevent it. That does not mean that no one should have it. Some situations do warrant closer surveillance, but everyone automatically is not supported by the evidence. And that really, really matters. So if you're pregnant or you're planning to be, here's what I want you to know. Just because something is hospital policy does not mean that you have to do it. Just because something is hospital policy does not mean that you revoke your human rights. And if you are not given true informed consent, you are not required to do anything. So some questions that you can ask if you're in the process of figuring this out are, what's the evidence for continuous fetal monitoring in my situation? Because who knows what your situation is? Maybe they have a really good reason for wanting continuous. Another good question to ask is, are there any alternatives? I'm happy to get hooked up to intermittent monitoring every 20 minutes if you need me to. Will that suffice? And just overall, know that you have options. In most cases, intermittent monitoring, where a provider checks the baby's heart rate periodically rather than continuously, will give you the same information without keeping you tied to a machine for hours and hours. Some birthing people find that difference of being able to move freely can make a profound impact on their birth experience and their ability to feel autonomous in labor. Ask questions about your hospital's culture. Sometimes you don't have a choice where you're having your baby, and some hospitals are more flexible about monitoring protocols than others. And knowing this ahead of time can really help you make informed choices, and it can allow you to change your mind. It's never too late to change where you're giving birth or change your provider. And if you do end up with continuous monitoring, it's okay. That is not the end of the world. Birth is so unpredictable. But knowing why it's happening and that it is actually necessary for your specific situation makes a huge difference in how you experience it. Okay, here's what I just keep coming back to. The routine use of continuous monitoring on every laboring person is a perfect example of how good intentions and fear can override evidence and intuition. It shows how business incentives and legal liability can drive medical practice, how hospitals normalize things, not because they're supported by research, but because they're easier or because they look good legally. At this point, 1 out of every 3 babies is born via cesarean section in America. And that rate far exceeds public health recommendations, and the most common reason given for a cesarean in a healthy pregnancy is fetal distress, a diagnosis made by that monitor that research shows often is misinterpreted. So we can do better, and we should do better, because informed choice is not just about respecting what people want. It's about giving them real information so they can make decisions that actually serve them and their babies. It's not what's easier for the system. It's not what looks good in a lawsuit. It's what actually serves people who are having babies. And that's how we move from surviving to thriving. Thank you so much for listening. This episode is part of my mission to give you honest, evidence-based information about pregnancy, birth, and postpartum and babies so that you can make choices that feel right for you and your family. If this resonated with you, please share it with someone who's pregnant or thinking about pregnancy. These conversations matter. You can find more resources, the link to the New York Times article, a link to the Beyond Birth Blueprint, and everything you need in the show notes. Next time on the Be Well Baby podcast, I'm sitting down with Johnny Long, a photographer and filmmaker who has actually been collaborating with me to completely reimagine how we visually represent perinatal care in stock photography. But more than that, he is a partner and a father willing to open up and get really, really vulnerable about supporting someone through pregnancy and birth and postpartum. We talk all about communication, partnership, grief, and what it actually looks like to show up for someone that you love. Thanks for being here, and I'll see you next time.
New episodes drop every Wednesday, and you can find us wherever you get your podcasts. Follow me on Instagram at BeWellBabyPDX or just visit BeWellBaby.org. Send an episode to someone who's pregnant, postpartum, or just needs guidance. No one should have to do this alone. Welcome to the Be Well Baby podcast. You're in the right place.